Dr. Neha Dholakia presents the IOL cutting tip and forceps. Broken IOL complications have been the most dreaded for years. We've been using techniques that are traumatic to the wound and the endothelium. The snare technique, which cuts the IOL into two. The twist and out technique, which requires a swift and skilled surgeon and can stretch the incision if not performed properly. IOL explantation through a cartridge can stretch the wound. IOL scissors, which are bulky and need extension and thereby getting post-op cylinders, striate keratitis and even Descemet's detachment at times. Introducing this innovative tip which makes it easy for any surgeon to cut the IOL extremely easily into 3 or even 4 or even 5 parts. Each sliver is only 2 mm in width and hence can be easily removed through a 2.2 mm incision without stretching the wound or extending the wound at all. Indications for IOL explantation are broken IOLs at the time of injection due to jamming of the cartridge, opacification of IOLs, subluxation or dislocation of IOLs, an IOL exchange required for unhappy patients due to halos and glare in trifocal or ringed IOLs. The forceps are made of steel as they have to be strong, while the tip is made of titanium. You have to prime the phaco machine with your regular tip as usual. Then remove your phaco tip and then attach the new IOL cutting tip. Tighten it. One has to make sure that while putting the sleeve on, the holes are perpendicular to the teeth of the tip as they can engage the sleeve. The tip must be a little more out than usual. The forceps are such that the jaws open and close vertically just like the mouth of a crocodile to grip the IOL, but the grip is such that it is horizontal and opens and closes parallel to the ground between the thumb and the middle of the index finger. It is ergonomically designed for the ease of use. The surgeon introduces the forceps through the side port and gets a good grip of the IOL. The vacuum and aspiration are at 0, irrigation is on. Then the surgeon positions the tip and simply presses on the foot pedal. The IOL is cut just like butter, so easily within 1 second, and the pieces can then be removed through a 2 or 2.2 mm incision without extending or stretching the wound. This is an in vivo demonstration of the same. The IOL is being cut into slivers of 2 mm each, and each sliver can be removed without stretching the wound. The pieces have to be aligned parallel to the incision such that each piece can be removed efficiently without damaging any part of the eye. This is a case beautifully done by an esteemed colleague of mine. The patient was a 60-year-old male patient who was one-eyed, living in Dubai, driving every night, and wanted to be free of glasses as much as possible. During the primary surgery, the injector got jammed and the surgeon had to manipulate the IOL to bring it out. This created a dent on the IOL. Though the patient was 6'6", the next day he had a lot of dysphotopsia due to the dent in the middle. As the patient was traveling back to Dubai, in 4 days the surgeon decided to use the IOL cutting tip and forceps. He goes through the same 2.2 mm incision and cuts the IOL into 3 parts. There is a continuous injection of dispersive viscoelastic to protect the endothelium. The power was only 30 on his Centurion machine. If he had extended the wound to 6 mm, it would have given rise to a lot of astigmatism. If he had used the twist and turn technique, it would have stretched out the wound and led to wound damage, and one requires to be very skilled and swift to do that. If one had used scissors, that would still need extension of the wound to at least 3 mm. Both the surgeon and the patient were thrilled on day 1 post-op as the vision was unaided plano 6/6. So this wouldn't have been possible by any other technique. One must try and use the IOL cutting tip in vitro before using it in vivo. The power has to be continuous and the vacuum and the aspiration have to be kept at zero. Giving good counter pressure with forceps is extremely important as that minimizes the use of any higher phaco power. One can start with phaco power of 50% and then go down to 40, 30 and 20 and see the least phaco power with which the tip cuts the IOL. The jaws do not open and close but just use the ultrasonic power of the phaco machine to cut the IOL, which is much better than any mechanical force. The temperatures were also tested on the regular phaco tip and the IOL cutting tip, and they both were found to be the same. There are 6 different lengths, 3 different threads and 2 different thicknesses for different phaco machines for the IOL cutting tip. So please do not try to interchange these tips. There are different tips provided for different machines. This gives the least phaco power delivered at the tip for cutting the IOL and hence the least endothelial damage. This can come to rescue if an IOL breaks at the time of injection. One can keep it as a standby in the OT just as we keep the vitrectomy cutter. This is commercially available at iolcutter.in and also on Instagram iolcutter and forceps. Advantages over the other techniques: can easily explant an IOL without extending the wound at all. There is no tilting of the IOL with the scissors. There is no stretching of the wound. No special surgeon skills required. One can cut the IOL into even thinner slivers if the need be. All in all, this technique uses the ultrasonic power of the phaco machine and removes the IOL, respecting the posterior capsule, the wound, and most importantly, the endothelium. Thank you very much for your patient listening.